Hello and welcome to another edition of Health in the Heartland, a program dedicated to the health issues that affect you. I'm Karen Blakelock, and joining us this episode is Dr. John Cole and Dr. Thad Jackson, neurosurgeons with Heart and Memorial Health. Thanks for being here today.
Good morning, Karen. Thanks for having us.
Dr. Cole, let's start a little bit about what actually is neurosurgery, and maybe giving our viewers kind of an overview of what a neurosurgeon typically sees.
Sure. Neurosurgery is a surgical subspecialty that's concerned with care of the central nervous system and peripheral nervous system. So that's the brain, the spine, the spinal cord, and the bony structures around the spinal cord, as well as peripheral nerves that go out into the hands and arms. Is essentially what we take care of.
So generally, the patient might see their family practitioner have some signs and symptoms, and they get referred to a neurosurgeon?
Correct. Most of our practice is referral-based or emergency-based. Not many people seek out a neurosurgical opinion unless they have some underlying condition that has been formidable for their family practice doctor to help control.
And I think you hit a good point, Dr. Jackson. So most of the people that you would see, and you both work, I know, together, would be maybe from injuries and then also from chronic disease processes?
Yes, a lot of car accidents, traumas of some type will maybe have a broken back or a broken neck, and of course they will typically see us, sometimes in the hospital if it's a stable fracture, sometimes in the clinic, treated with a brace or other modality, sometimes surgery. And then, of course, there's chronic issues, back pain, leg pain, things like that, that will try multiple things with their doctor, and maybe they're not getting appropriate response to the treatments, and so then they will be referred to us for a second opinion to give them an idea of if there's anything else that can be done to help reduce that pain.
Excellent. And we've talked about the brain and the back. In this episode, we're really going to focus mostly on back pain, because you do typically see a lot of individuals that have back
Sure.
concerns. So tell us a little bit about the number of back pains and I guess what they typically come to the office complaining of.
Sure. I mean, back pain is an incredibly prevalent problem. Over the course of everyone's lifetime, about 60 to 70% of the population has back pain at some point, which is anywhere from mildly incapacitating to totally incapacitating. The good news is that the most common thing we see is that it's a self-limited problem, and that most people recover within a relatively short period of time. 6 weeks to 12 weeks is a typical recovery period. And most of the time, primary care doctors are pretty facile in terms of helping to control the discomfort that patients are feeling. The bad news is that it can be a recurrent problem. 30 to 40% of the population does have a recurrence, and often people will enter into a sort of a cycle of injury and recovery, and it's referable to many different things. But the important thing is to understand that there are certain things that we should look into and sort of evaluate and vet the circumstance in order to rule out particularly bad things. The good news is, again, that those are relatively uncommon.
So we know many people do suffer from back pain at some point, and generally as we get older we tend to have that happen a little bit more frequently. So probably more adults that you see than
Sure.
children with those areas. And it does cause a lot of lost work days and problems with people not being able to do their activities of daily living. Do you see more males or females, Dr. Jackson?
It's a pretty good mix. We probably do see more males, or at least it seems to be that way, but it's not a dominant, it's not like 80%, 20%, it's maybe 60, 40% male to female. But, and that's in general, not always, but obviously in general, males will sometimes do more construction type work, or heavy labor, heavy equipment operation tends to be more male dominated field. And so we see a lot of those patients who really hurt their backs. We see a lot of military folks who done 20 years of heavy military work who will hurt their back through that. So we do see a lot of, probably a little bit more male, but it's certainly not just a male disease by any stretch of the imagination.
Now, what are some tips maybe? We know we're looking at a lot of preventative medicine now too for individuals, maybe not to have some of that back pain. What are some things that they could do, Dr. Jackson, that might prevent some of that back pain? Just I'm talking those individuals that don't want to have that
Oh,
maybe down the road.
Well, it's strange enough, smoking is bad for your back. A lot of people don't realize that, and it's not actually just smoking, it's nicotine use. So smokeless tobacco and cigarettes, both are bad for your back. So that's one tip, is to work on nicotine cessation or smoking cessation. Second is just maintaining a healthy lifestyle, so regular exercise, low impact typically for patients with back problems. It's not usually running and things like that or heavy lifting. It's more of swimming or walking. Strengthening your core is just crucial for your back health. So yoga, Pilates, there's several different core strengthening programs that are going to be very good to help protect the back. The muscles of your spine that surround your spine actually do the majority of the work of your spine. The bones and disc, which we hear about more often, only do about 20% of the work. And we can't really fix degenerative disc disease. It's a form of arthritis that we see in a lot of patients, but we can certainly strengthen the supporting muscles that help with this integrity of the spine and help it feel better, kind of shield it from injuries. So healthy weight, regular exercise, stop smoking if you smoke, and avoid activities that worsen the pain.
Absolutely.
Kind of easy ones.
What about sleeping? Dr. Cole, is there a better position for sleeping with back?
I don't think that there's a particular way to sleep. I think the sleep is a very individual process, and I haven't experienced in my practice that one particular thing precipitates an exacerbation of back pain. But I think that in terms of the things we do while we're awake, and if we're in the throes of an acute exacerbation of back trouble, that Dr. Jackson mentioned, really carry on too. Meaning that if you hurt your back, we don't want you really at bed rest. We know that is a bad thing. We want people to be moving about, and there's a lot of different other strategies that can be implemented to assist. For instance, dependent upon the degree of activity referable to someone's job, you can, a short course of interruption of their vocation may be helpful, meaning 0 days to 3 days for light labor and up to 30 days for heavy labor might help a person of people to make a recovery. The other things that you can implement are nonsteroidal anti-inflammatory medications like Aleve or ibuprofen at reasonable doses. Acetaminophen, Tylenol is a good drug, but understanding that Tylenol itself has a toxicity, and so being mindful of the total intake that you're having on a daily basis is an important thing that you can talk to your primary care doctor about. Muscle relaxers, and then short courses of opioids or narcotic medication. But the emphasis being on short courses. A week of narcotics is plenty for a back pain exacerbation, and then replacing that with high-dose anti-inflammatories is usually a good initial strategy.
And I think you brought up some good points, especially Tylenol has changed with how they're really trying to make sure people understand the new labeling and different things too. So those of us that have had it around for a while really need to make sure we're reading what the dosage is before and talking to their healthcare professional about that too. What about heat and cold? You hear different things?
And I hear it from different therapists even will recommend different things to the patients, and I tell the patients what's comfortable. I personally don't like cold on my back. It makes my back feel bad if it's bothering me, and so I would typically use heat. So I tell my patients, I really individualize it to the patients. And the same thing with, I think, Jay, you mentioned about sleeping. Some people like a really firm mattress, and some people like a soft mattress. Some people like a memory foam mattress. Some people like that air, whatever, the sleep number bed. It's just variable from person to person. And so, again, it's very individualized, and so it's a little bit of trial and error. If somebody comes and says, I'm going to get a Tempur-Pedic mattress, I say, well, get the warranty so you can return it if you don't like it, because some people like that type of mattress, and some people, it really makes them feel worse. And so it's extremely variable. There's not one answer per person, and that's what I say. You really have to look at that person's risk factors and that person's individual problems. Is that person obese? Is that person out of shape? Is that person, do they never exercise? And then try to come up with a kind of a multi-dimensional plan to try to help reduce their back pain.
I think, and when I mentioned the sleep, actually I had heard over the years, not sleeping on your stomach, mostly sleeping either on your side or on your back, just because of the not being in its natural position.
Most data would agree that sleep, and not a lot of people tend to sleep on their stomach, but as far as the back versus side, I've read one article that said you should sleep on your side with a pillow between your knees, and I've read several different articles trying to get recommendations from my patients, and there's not one specific one that seems to work the best. I'm a back sleeper, so I guess I do that, but yeah, I think stomach sleeping is generally thought not to be good, but between the others, it's not really known to be significantly better.
And I was going to say, I like what Dr. Cole mentioned, because you usually hear when somebody has the back pain, they get quote unquote laid up, or they're in bed, and so you're really trying to get them back and active as quickly as they can. Sure. So getting on that medication, and then you had mentioned therapy. So is that something, Dr. Jackson, that
we will? Oftentimes, a lot of times the patient doesn't want to participate in therapy right after an episode of back pain because it hurts too much, and so they don't like to get pushed on and things. But after a couple of weeks, if the back pain's not starting to improve, that's something we'll often try before, say, going to an MRI or something like that to see if there's some other issue. Assuming there are no red flags, we usually don't get an MRI of the patient's back for 6 to 8 weeks after the onset of their back pain. And red flags meaning significant leg pain or weakness or loss of control of their bowel or bladder function or a history of cancer or anything like that would make us a little more worried that they might have something else going on. So usually we'll try some conservative things first, and this is actually typically the primary care provider who's trying these conservative things first, and then if they failed those things, that's when we're going to look more into the problem. Like I said, usually after about 6 weeks or so, we would be typically heading towards an MRI or another imaging study to get a better look at what's going on, just to assure there is nothing bad or untoward that we didn't expect to find. Because as Jay mentioned, low back pain is almost always self-limited. Not 80% of patients are better at 6 to 8 weeks. So if we MRI'd everybody who came to their doctor with a low back pain the first day, that would be a huge cost to our healthcare system. That would be unnecessary. It's not at all uncommon for me to see somebody who had an episode of back pain. They got an MRI in the first week of their back pain. They went to see their doctor. They were referred to me for back pain, and there were some abnormalities in their MRI, some degenerative disc disease. And by the time they get to see me 4 weeks after the onset of their back pain, they're fine. They just want to see me just in case it happened again. And that's not at all an uncommon scenario. And to be honest, that person never should have gotten an MRI to begin with, and they never would have seen me, and they never, they would have gotten on well on their own. But that's certainly an issue, education with everybody to say, okay, it's to understand that it's typically going to get better. Yes, it's not just an MRI the first time you see the doctor with back pain.
Exactly. And I think you talked about the steroid, different things for the anti-inflammatory and kind of making the swelling going down so you can check and see what's going on. And then you jump into taking a look at the x-rays and the MRIs and different things too. And then potentially surgery if needed.
Sure.
What patient would need surgery? And I heard you mention, Dr. Jackson, the numbing of the legs. What else, Dr. Cole?
So surgical patients are a relatively small subset of back pain patients. Patients who have underlying malignancy, so patients who have a cancerous tumor or a benign tumor sometimes can present with back pain. Those are patients that we typically would consider operating on. Disc herniations, patients who have leg symptoms, often you can have some proximal leg symptoms in your buttocks or things of that nature, but leg symptoms that go below the knee are more viable surgical candidates. In terms of back pain, only 4% of patients who have back pain actually have a surgical disc herniation, and perhaps 2 or 3% of patients have an osteoporotic compression fracture. More commonly in some of our elderly female patients, they're prone to osteoporosis and having fractures. Those patients can ultimately be surgical patients as well, but there are some conservative measures that we implement in order to try and save people going through surgical endeavor unless they need it. But patients who have congenital abnormalities, tumors, as I said, or degenerative process that are pretty profound, where they develop a slippage of and a malalignment of the spine, can be managed with a surgical intervention.